Hello, everyone. My name is Samuel Yeboah-Manson, and I will be presenting about the effects of race-based medicine on the health of BIPOC communities through a psychological lens. BIPOC is an acronym that stands for Black, Indigenous, and People of Color. And this topic is essential to global health because without addressing sort of the inequitable parts of medicine and healthcare, and how it disproportionately affects certain communities, we can never really make strides in providing accessible and equitable healthcare for everyone. This is a little bit about what I will be talking about. And so about me, I'm a rising senior from South Windsor High School in New Jersey. I am the vice president of my school's public health club, class council historian, and I volunteer at an environmental nonprofit. And also this summer, I was able to intern at the Rutgers Cancer Institute, where I learned about and researched a little bit about breast cancer. So race-based medicine, by its definition, is a system by which research characterizing race as an essential biological variable translates into clinical practice, leading to inequitable care. So by its very definition, race-based medicine is inequitable. And this is because in medicine, you often have to research based on explicit hypothesis, but in race-based medicine, this hypothesis is less explicit, and diagnosis and treatment rely on the main belief that people of color and whites are genetically different, which is obviously problematic. Here's a little history about race-based medicine. Really began with scientists viewing African Americans as genetically inferior to justify slavery, and intellectual leaders began to take a hold of this and kind of build into their framework, and obviously has implications in the Constitution and in different legal documents. And by the 19th century, race had taken a meaning equivalent to mean like species and was used to categorize the differences between whites and other people of color. And today, race is considered to be one of the biggest hot button or hot topics in America, and research still continues to be done into its implications. So a prominent figure involved in race-based medicine is Samuel Cartwright, who was a physician during the antebellum period of the United States. He discovered quote unquote diseases like drapetomania, which supposedly caused slaves to run away, and Dysesthesia aethiopica, which caused bestiality in Black people. Obviously, those diseases are made up and have no real scientific bearing, but he claimed that these diseases kind of plagued Black people and that they actually desired to be enslaved and were physiologically and intellectually inferior and meant to be subservient to the white race, and also claimed to conduct scientific studies of Black people and said that they had smaller blood vessels and brains and were inclined toward barbarism. So now moving into sort of the psychological aspect. So biases are very prevalent in race-based medicine and just the equality within healthcare. Implicit and explicit biases are the two types. Implicit, meaning that you don't have conscious knowledge of your bias or attitudes towards people, and explicit, meaning that you do have conscious, you are aware of the prejudice and attitudes toward certain groups of people. And biases very much impact how different racial and ethnic groups receive care, because people or physicians who are more biased are less likely to give favorable or adequate care. So according to the National Academy of Medicine, racial and ethnic minorities receive lower quality healthcare than white people, even when insurance status, income, age, and severity of conditions are comparable. So like I said before, bias is affecting the healthcare that people receive. And it's not like physicians have a lower percentage, or it's not like there's a lower percentage of physicians who have biases than the general population. The numbers are roughly the same. And this is affecting people's lives and how they are able to move through the world. Moving on to the more tangible effects, affects things from treatment to operations to recovery. For example, Black patients with heart disease receive older, cheaper, and more conservative treatments than their white counterparts, according to the National Academy of Medicine. they're less likely to receive coronary bypass operations and angiography, and they're discharged earlier from hospitals than their white counterparts. Out of the stage 1 discharge is inappropriate. So these biases and how people view African Americans or other people of color definitely have some tangible effects on their health and on the health consequences of larger ethnic and racial populations. Moving on to representative heuristic, which is sort of similar to a stereotype. It's when we estimate the likelihood of an event by comparing it to an existing prototype that already exists in our minds, and the prototype is what we think is a typical example of such an object. So, for example, a lot of physicians believe that Black women are less likely to feel pain, which is a prototype, and they translate this to other Black women, even though that's not always the case. And by this, they're less likely to give pain medication to Black women, or when they do, they give lower dosages. And this translates to the maternal mortality rate disparity between Black and white women. According to the CDC, the estimated maternal mortality rate is about 17 per 100,000 live births in white women, but it is 43 per 100,000 live births for Black women. And this disparity just goes to show how really what tangible effects race-based medicine and biases coupled with stereotypes or prototypes have on the health of a larger population. Also moving on, African Americans in particular are severely impacted by this as well. And according to the US Department of Health and Human Services, they have the highest mortality rate for all cancers compared with any other racial and ethnic group. So again, this bias is indirectly killing people because doctors who have more bias are less likely to take the symptoms of the people they have bias against seriously, which leads to worse health outcomes. So what does this all mean? So stereotyping is partially responsible for how doctors actually treat different patients, but the blame also lies within systematic structures of healthcare and how it kind of punishes people of color and lower income people. So differences in treatment lead to differences in outcome. And if one group is more neglected over another consistently, the health outcomes of that particular group will be disproportionately worse, which we have seen is the case. And also the history of quality of care that many BIPOC individuals receive is likely to lead to medical mistrust, which kind of creates a cyclical aspect that I'll talk about. So the history of deception, abuse, and exploitation at the hands of a system that is supposed to help, the healthcare system, kind of leads to a refusal or hesitancy to take actions based on past medical experiences. And this kind of like, the two are kind of contingent upon each other and one causes the other. And the prototype that is formed of hospitals and doctors based off bad experiences with both kind of also leads to that as well. And socioeconomic factors also play a role in the lack of action. 63 and 46% respectively is the percentage of Black women and Black men that have said that they received one of the seven negative healthcare experiences measured in a survey conducted by the Pew Research Center. So this just goes to show how widespread bad experiences are with hospitals and doctors, and how having more bad experiences makes people less likely to want to visit a doctor, which leads to worse health outcomes. So what should we take away from this? The healthcare system disproportionately punishes BIPOC and low-income individuals. And healthcare also needs to shift away from race-based medicine, where race does not play as much of a factor in determining a patient's course of treatment. And finally, this is less of a statement, more of a question. What other factors are responsible for the healthcare disparity? I touched upon a couple, but there are different factors that have a role in determining someone's health. And the more we learn about these factors, the more we can try to reduce their impact. These are my references. And I would like to thank my family and friends for supporting me, the board and advisors of Students for Public Health Club at my school for providing me with the opportunity to serve on the club board and kind of cultivating my interest in public health, the GHLC team and attendees, and Dr. Dorothy Roberts, who first inspired my interest in race-based medicine. And if you would like to contact me for further questions or to discuss this further, my email is here on the screen. Thank you so much and have an amazing day.